Hello, everyone, and welcome to Innovation Health Jam. I'm John Nasta, and today we'll be talking about patient engagement and designing healthcare. We've got a fabulous group of people, and we'll have a provocative discussion today. But to frame up our discussion a little bit, I want to walk through some fundamental issues that can help drive our discussion. It's important that we recognize that one size does not fit all, and today we'd like to discuss a little bit about issues around gender and age, geography and regional considerations when we're crafting information to patients, as well as things like language and education. Because if you're talking about a patient with a condition or a consumer or customer with a condition in Boston, that might be very different than someone who's in Atlanta. And finally, that style and content is very, very important as we discuss some of these issues. We'll also like to take a look at understanding the clinical condition. When we speak to patients, it's often in the context of a disease type, the patient with asthma versus the patient with a condition like cancer. Also, the idea of prevention is an important context that we'll try to touch base on. And also, sometimes you're not only talking to a patient or a person with a condition, you're speaking to a parent or a caregiver. So those are other important issues. And then we'll move beyond that scenario and look at the role of the healthcare provider and the payer and how we can activate these people through a surrogate, if you will. The premise of build it and they will come may be correct, it may not be correct. So I'm looking forward to the panel's discussion about that. The role of the healthcare provider. Will the physician drive activity? Can the physician be an advocate for the patient? And also, what's the role of the other healthcare providers, such as the nurse and even the pharmacist? Also, a key issue will be the role of incentives. How do we get people off the couch? How do we get them to engage in these behaviors and drive wellness and health? And finally, does it take a village? Is it really a constellation of some of these issues that will help us frame the discussion? So I want to open the discussion up to our group and talk a little bit about that first question of crafting a message to a patient where we're talking about a condition or an environment where it may be relevant or may not be relevant to them. So maybe, Kyra, you can start off and correct me for saying patient right out of the box. I know that was a hot button for you.
Hi, John. This is Kyra Bobinet. Yes, so I think the main thing is that people don't always feel like a patient. You know, even if you have a very serious illness that is consuming your life, 99% of your time really is not in front of the doctor. It's not in the hospital, that kind of thing. So to approach it with medicalizing people and to cast an image on themselves that they may not adopt or they may not feel that they are a patient, they feel like they are Kyra or whatever their first name is. And that means a lot of other things. They might be a gardener, they might be an athlete, they might be a grandmother, they might be all kinds of things that in their head is much stronger and more resonant. And so all communications, all products, all kinds of approaches with engagement have to fit that self-concept first and foremost.
Amy, I want to ask you a question about, we talked a little bit earlier about the context of someone in your family have a condition. This morning I spoke to my mother about atrial fibrillation of all things. And I find myself couching that language in a very different way that maybe we would talk to other people in our family with different conditions. How can you comment on that a little bit, please?
Yeah, I'm actually really passionate about identifying and addressing unmet needs in health, and I think there's a lot of unmet needs surrounding recent diagnosis situations. The recently diagnosed, they sort of fall into a canyon where they're left to sort of figure things out on their own. And I think that if we look at the peaks in emotion that people have, that can key us into where there may be unmet needs, and if we pay attention to that, we may figure out how to build bridges and collaborate to help people get more progress.
Amy, I want a question, then I'm going to move it over to Jane next. But you used a very interesting word to me, and you used the word emotion, and how these are very emotional times. What can we learn about that in terms of crafting communication?
Everyone involved has emotion. In the industry, if our emotion is telling us this just isn't right, why can't things be better? We need to pay attention to that. I think we can become desensitized when we're trying to solve the same problems again and again, with or without results. But we need to remember to engage that emotion and our empathy, because that's going to inspire us to innovate on the behalf of people who really need us.
I want to move over to Jane and talk a little bit about the context of building a story that's relevant to a particular patient type, whether that be age, gender, the type of language, the style, and content, and talk a little bit about your experience, how one size does not fit all.
I think a useful construct to think about is something I worked on a long time ago with Institute for the Future, called something called personal health ecologies. If you think about all the choices we all make every day, from morning till we go to bed, we make lots of decisions that impact our health. It could be walking more, walking less, eating right, not eating so well, shopping for healthy food or not, parking far away from the front door of the office, etc., taking stairs, not. So when we think about crafting messages, we have to think about where the person is. Can we get them where they live, work, play, pray, go to school? And all those moments of truth throughout the day can be touch points for communicating to people within the context of their lives so that we can be relevant to them. And I think new technologies give us the opportunities to do that, whether we think about the mobile phone, group chats like we're having now when the technology is friendly to us.
Let's talk a little bit about attracting or driving the patient with incentives at the right time in their journey, and perhaps even with the right incentive. Michael, you're the expert in this topic. I'll hand it over to you.
If you think of all the topics we've covered, whether it's how you designate the patient and the personalized experiences, the specific place in the healthcare system they're interacting with, or the particular condition that they're dealing with at a particular point of time, that's pretty overwhelming to the normal consumer, if you will. And so the ability, like many other industries, to align incentives and rewards to the behaviors you want them to take. You know, if you think about other industries, they're really expert, whether it's credit cards, airlines, even your local coffee shop, about aligning you to the right types of behaviors. So take something as complicated as healthcare, which most people have a difficult time, manipulating through, just trying to understand where they're supposed to go and the condition that they have. Personalizing those incentives, making those incentives relevant. A simple example is, in the e-prescribing world, if you give a physician that makes $250,000 a year a $50 incentive for activating their e-prescribing account, and you give that same $50 to a $35,000 a year nurse administrator, you'll get a completely different result. Really, within healthcare, it's one of the few industries where we ask people to change their behavior without giving them incentives and rewards. So I think that's pretty foundational to this kind of personalized, consumer-centric approach.
The right incentive at the right time, initial diagnosis, chronic care, old, young. As I build out this matrix, it's getting really complicated to me. Is technology part of the solution in managing this complex matrix?
I think that technology should be framed as an aid in terms of what it can lift and what it can't lift. And I think that it can lift single things, like an app is kind of a one-trick pony when you think about it. It's usually good for one thing, with the exception of apps that connect you to other people, which then becomes this whole other world of customization that kind of goes on auto. The technology can, on its own, without any other humans involved, if it's just completely inanimate, if you will, or it has an AI component to it, it can be as predictive as possible. But in terms of healthcare and the complexity that Michael was talking about, we have to navigate it, and the only way that technology can help us do that is to link us to other humans at a certain point in complexity or where we reach a dead end. And so I feel like we have to really understand where technology kind of, its use case kind of ends, and where humans have to pick up. That transition place is probably the source of a lot of the loss of engagement in the healthcare system, where we have drop-off, we have a crack in the system, where we think the technology should be able to carry it this far, it only carries it this far, and then it dies, and then it's become an inanimate object in people's lives. And that's where you hear people say, I just need to talk to a person. I need to talk to another person like me who's facing what I'm facing. I need to talk to somebody who feels like, so I don't feel alone, or I feel like somebody actually cares, and not some machine cares, but some actual person. And that need will never go away, and it will never be replaced by technology, although it might be aided by technology.
As an industry, we want people to do certain things, follow through with their treatment protocols and look at their fitness and their nutrition and their stress levels and follow through and change their behaviors. As we know, change is very difficult. We need to, as an industry, move beyond manipulation, of course, in its purest sense, and get to the core of what really motivates people intrinsically. Working on behavior change applications, and I think behavior change applications can provide the construct and the method for even natural remedies and pursuits, and they're getting to the point, apps are, where they're clinically proven to improve outcomes to the point where they may be prescribed. Self-determination theory, which says that there are three principles there, and I think they're important to think about. One is humans have a need for connectedness, and I think this is what Kyra was talking about, to relate to others who may be at the same point in time as them, or further along and have been through it and can lend a helping hand or some tips. Also, autonomy. So if the system is trying to control me, I'm going to rebel against the system. So how do we provide tools that enable people to pursue their independent path, and one that they choose and they have control of?
I want to move the discussion forward a little bit and talk about the notion of connecting with a patient in the context of disease. Because, as we said earlier, a patient who has an unsightly rash may be a different communication stream than someone who has a life-threatening condition or even a terminal condition. So I'm going to go to Jane first and talk about perhaps the nature of a specific disease and how that might change, or how that may be a common ground in terms of communicating with patients and caregivers.
I think this is all contextual. This is based on an individual's perception of risk, which is something we have to take into account. In some cultures, people believe in more self-care. If I go to East LA and somebody's diagnosed with a heart condition, they might go to their local herbolista to get a bunch of different treatments that are natural treatments. There are other people in our society who believe in 101% Western medicine, and we have to take these cultural and social dynamics, individualistic characteristics into consideration. I know some healthcare companies, life science companies, who started to do this, looking well beyond male, female, Hispanic, Caucasian, et cetera, to start targeting programs that speak to people's multidimensional approaches to managing their health. And we have to do that. Take the case of somebody newly diagnosed for a form of cancer for which the cost of the treatment is, say, $100,000 a year. And they have a coinsurance of 50%, which is a likely scenario today. There are some families who can take that financial commitment and spend the money, and other families who say, I have 3 months to live. I am not going to spend the money on that. I want to die at home, and so forth. So there are, we're talking about serious illness, maybe terminal illness or chronic and then terminal, as many cancers are. We really have to understand people's risk-loving or risk-averse behavior, and I think the financial issues are really important today as well.
Michael, you know that I'm a big fan of providing appropriate incentives. How do you stratify incentives across the continuum that Jane spoke to? For example, an oncology patient versus a patient who might be on amoxicillin for 10 days. The complete sort of different side of that care. Are there any insights about the way that's stratified, and is it better to do one versus the other in certain patient populations?
When you think about, end of life and terminal illness, those are not situations where incentives are really meant to be inserted. But if you think about the continuum from folks that are generally well, low risk factors, all the way into chronic, there's behaviors along that continuum, if you will, that are critical. I mean, your example of prescriptions, a sizable number of folks don't even get their first prescription filled. If you look at people on Medicare, right, 6% of people take advantage of their free annual WellCare visit. As you get into more serious disease states and more clinical diagnoses, that's where incentives become a little bit less relevant. I mean, even when people have serious illness prior to, end-of-life situations, there's many behaviors within chronic conditions. Take diabetics. Everything from, annual exams to medication to obviously lifestyle behaviors, where incentives can be strewn throughout that whole process. So there absolutely is, to Jane's point, there's a seriousness to which terminal illness comes about that incentives may not apply, and there's other stages of both disease and life where incentives are very relevant. So it goes back to our points earlier about really it having to be, personalized and customized.
Good. Kyra, a question over to you about the proverbial human connection. And how do we make those connections in the context of disease states? When I think about patients or family units touched by Alzheimer's disease, comment on that, because I think it varies. Or I go back to the notion, is there just a fundamental human connection that transcends a particular disease state?
My little recipe for reaching people across all disease states is threefold. One is people need to know that they're not bad. Number two, they're not alone. And number three, there's a way out. There's going to be a different ecology surrounding each of the kind of emotional, behavioral mixes for each individual person, as well as you could probably group them by the intensity of emotion in particular around a particular condition. So if you have a disease that is a long track and it's not really that present right now, it's not life-threatening today, what the brain does with that is it parks it, and it's hard to stay really alert to and attentive to what you need to do for yourself. On the other hand, if you have something that is really imminent and really, very disturbing, like an Alzheimer's or like a cancer, something that you've seen people or heard really horrific stories about it, the emotional temperature is very high, and that can spring into action. To Michael's point, there's not a whole lot of incentivizing that needs to happen to kickstart somebody's motivation into high gear, or in some cases, to Amy's point earlier, they hunker down and become paralyzed. I feel like we have to be more skillful around understanding the emotional profile of not only the condition and how that affects people at large, but also how that interacts with that individual person.
But Amy, I know that I see your head nodding a little bit, and I want to give you the opportunity to come back around and talk about the condition and the disease.
The third tenet of the self-determination theory is competency. People have a need to feel that they are competent, that they are doing what they need to be doing, what they want to be doing, and that they are accomplishing the goals that are set in front of them. And so if we make the goal and the challenge too high and they're not able to be successful within that, they'll quickly disengage. Or if the challenge or the goal is too easy, then they're not going to feel challenged and will not stay engaged. And what you're talking about, emotion versus cognition, there's an interesting metaphor from that. For that is that the elephant and the rider, the elephant being the emotional being that reacts with the fight or flight, and the rider being where our intellect resides.
I want to talk a little bit about the role of the healthcare provider. And the healthcare provider is a very interesting topic, because sometimes the healthcare provider is Dr. Mom, and sometimes the healthcare provider is Dr. Kyra. So, Kyra, perhaps you can pick up on the discussion of the role of the healthcare provider as someone who facilitates and validates a message to support behavior on behalf of the patient and the caregiver.
So, so often, whenever you measure what people really listen to, online, they look at WebMD. In person, they want to hear everything from their doctor. And the squeeze is that the industry has taken most of our time away from the traditional provider that we go to see for visits, for example. And so I think there's a paradigm shift that needs to happen where we start to recognize exactly how much we are doing for ourselves and how much our family members are doing for us, and really validate the care that's being delivered at the home by the family and being self-managed. And I really like this idea of people stepping into, it's me. I'm the care provider. I'm the one who chooses. I'm the one who is the designer of my own health, my own destiny. And so I would like to see us really have products, services, those kinds of things that are empowering to that. I think that seeing things like iTriage as an app or those sorts of resources in the world really put the power of that information and also those algorithms in the hands of common everyday people. And I do believe that as the industry disrupts, that is what's going to happen ultimately, because it's already happening. And this whole veil of us looking almost childlike to this paternalistic healthcare system is starting to unravel. And that's where the natural engagement comes into play, or that we even acknowledge that, hey, we already are engaged. It's just that I'm actively choosing to enjoy this hamburger over enjoying my health in the future. And the more we understand the dynamics, the mechanics of our choices, and acknowledge the fact that we are always choosing things and we're saying yes to things all the time, even if we say no to the prescription and the industry marks it as 50% unfilled, we can still own that and say, yeah, because I chose to override my provider's recommendations. And you see that all the time. The new generation of providers who are really seeing themselves as partners and collaborators, and understanding that they're going to get a lot farther with the patient's health if the patient is actively bringing in information from the outside.
Is this quantified self and the democratization of health going to empower the patient? Does it run the risk of alienating the healthcare provider?
As providers get paid for value in whether we call it accountable care, bundled payments, pay for performance, they will be on the financial hook for delivering outcomes. You can't do that without what Kyra talked about, which is co-creating health between providers and patients as a team. And when we think about the team on the provider side, the physician, especially the primary care doctor, can't scale fast enough to provide that level of care, intimate care, with patients. So she, like Kyra, will be working with nutritionists, diabetes educators, podiatrists, dentists, and behavioral medicine specialists especially. We have to get more mental health into primary care so that people can take on this mantle of self-care. As our colleague Leonard Kish wrote about a year and a half ago, an engaged patient is the blockbuster drug of this century. And if we don't engage patients, we can't get to that holy grail of bending the cost curve, which as a health economist is, my passion, but also get better outcomes through having patients feel activated and supported. So it's not so much quantified self as it's quantified us. It's population health, and it's supporting in that village. So I think Kyra's right, and we have the tools to get there.
It's interesting because with quantified self and with all of the apps out there, the power is in the hands of the patient to track what they're doing and to start to understand themselves. And if these things are designed well, they can look at their own patterns and start to change their patterns and start to see benefits. What's exciting is that when the consumer has the data and they're in charge of their own tracking, we can start to see some of the offline things that are going on in terms of treatments that may be effective. Also, when the data is in the hands of the consumer, they can share it freely. I think one thing that's actually a barrier to the collaboration, the co-creation that we're all sort of talking about is actually HIPAA and how the industry handles HIPAA. I think HIPAA is often a barrier to innovation. The P in HIPAA stands for portability, but in fact quite the opposite is true as organizations face how to let people share their information and collaborate around their care. And in terms of fight or flight, it's flight. It's let's not deal with it, let's not enable sharing. I think if the patient is able to get their providers to communicate, coordinate, and to share their information with them, the more they know, the better.
Michael, you said something very interesting before. To give a physician $50 may be functionally meaningless, but to give a patient who makes $25,000 or $35,000 $50, that could be a much more powerful incentive. So how do you trade off some of the incentives with respect to healthcare providers versus patients with conditions?
When you really think of the duality, we're talking about the patient, and the provider. You really got to get alignment. And so, imagine the day where, in an ACO infrastructure, physicians are accountable for improving the outcomes of a diabetic, and yet that patient is going to leave the doctor's office and maybe not follow up on their medication and maybe not go exercise, maybe not eat well. So pretty soon, hopefully, you're going to have alignment of incentives where in that particular scenario, the provider would be incentivized for obviously the right type of care, but also the patient would be equally incentivized for following up on some of the things that I mentioned. One area where it's being used right now is preventing readmissions, where, pretty soon you'll have patients that are checking out of a hospital after a procedure and not just being walked through a care plan, but actually being say, oh, by the way, here's your care plan, and you're going to be incentivized with $500 if you go to your follow-up visit, get your follow-up tests, take your medications, eat right, whatever the particular protocol is. So I really think that if we align one constituent but not the other, I think you're going to have the dichotomy will play against each other. But I think it's in the not too distant future you'll have people, both the patient and the provider, aligned to the same outcome.
Well, one thing I've learned is that this discussion is robust and there are a lot of important issues. And for sure, Innovation Health Jam has begun today with our discussion, and we look forward to a vigorous and engaged discussion by our panelists and all of our participants. Thank you again for participating.